Epidemic as a Prevention Tool webinar series. The series is being brought to you by a collaborative effort from the North Carolina Division of Public Health, Injury and Violence Prevention Branch, and the UNC Injury and Prevention Research Center, IPRIC, and is an extension of the recent North Carolina Overdose Summit, and specifically the Prescription Drug Abuse Advisory Council's PDAC data surveillance and research teams. And of course, many other partners that have contributed to this work, including our two presenters today. Again, welcome. I'm Scott Preschel-Bell. I'm an epidemiologist at the Division of Public Health in the Injury and Violence Prevention Branch. I'm the principal investigator of the North Carolina Violent Death Reporting System, the North Carolina Prescription Drug Overdose Project, and the Enhanced State Opioid Overdose System. I serve on several state and national groups working to reduce overdose deaths, and I'm working to build capacity for general injury surveillance systems. I'll be moderating today's data discussion. This webinar came about as a direct result of the North Carolina Overdose Summit as a follow-up to the data session where we had several partners on a panel discussing using data in our state. Because the data session included more than 8 experts with very little time each, we decided that each would host a series of webinars so that the partners could have extended time to provide additional details around their data source or system. Today we have Tony Fernandez from EMS and Amy Ising from NC DETECT presenting. Tony Fernandez is the Director of Research for the EMS Performance Improvement Center, also known as EMSPIC, which develops and maintains comprehensive statewide EMS data for the state of North Carolina, South Carolina, and West Virginia. Tony oversees all the EMS data for our state, which is fast becoming a major player in overdose. As Amy Ising is the Associate Director for the Carolina Center for Health Informatics and the Program Director for NC DETECT, the North Carolina Disease Event Tracking and Epidemiological Collection Tool. NC DETECT has been a national leader in using ED data to track and monitor overdoses in our state. Today's webinar will be about an hour long. We'll have about 10 minutes at the end of the presentations for questions. We encourage viewers to submit questions as they come up in the Q&A box, which is found at the top of your screen. Phone lines will not be open for audio questions. We also encourage you to chat among each other and contribute to the conversation with the chat box. This can also be found at the top of your screen. This is the first of a series of data webinars scheduled to occur on the third Thursday of each month from noon to 1 Eastern Standard Time. To find out more information about the presenters or about future webinar topics, please visit the website that's being posted in the chat. We'll be recording and archiving this webinar. This webinar will be made available later this afternoon. Please check your inbox later in the day for an email with a link. Now I turn it over to our presenters. First Tony, followed by Amy. Thanks.
All right, well, thanks everyone. Let me get you seeing my screen here. All right. All right. Well, thanks everyone for giving me some of your time today. Again, my name is Antonio Fernandez, and I'm going to talk to you today about North Carolina EMS data and how you might use this for opioid tracking and prevention. So, as Scott alluded to, the EMS Performance Improvement Center is part of the Department of Emergency Medicine at UNC. And we serve North Carolina, South Carolina, and West Virginia with our 3 main applications and for data collection. Those are here. We have Premise, CIS, and SMART. Let's talk about SMART first. SMART is our resource tracking tool. It's the State Medical Assets Resource Tracking Tool. And this is essentially for disaster response and mass casualty management. This will be likely what we do here is we track bed availability, specialty services, resources, and the like. Excuse me. So this is more of a disaster preparedness application. Now we can get some things related to opioid overdoses here in terms of what resources are available for staffing and such. But this is one of our applications that likely will not be utilized as much for resource tracking. But here is the UI. CIS is going to be more, which is our credentialing information system. This is going to be more useful for folks for opioid tracking in terms of how you want to slice and dice the data. Some of the things we may want to look at for providers is what's the certification level of providers who are caring for these opioid overdose patients? What are their demographics? Were they paramedics? Was it a fire-based system or a private system? And what kind of education did these folks have? That's all contained within CIS. Again, we track state offices, regions, agencies, educational institutions, and we track vehicles with the credentialing information system. In terms of EMS professionals, we know things about their certification, their background checks, if they got reciprocity from another state, and we know what kind of education they've received and what their certification level is, whether they have a North Carolina certification or a national certification. Also, this is the UI, and again, what you'll see up on the screen here, that is the North Carolina Office of EMS contact information. Now, what we're really interested in and what will really be useful for folks is PREMIS. This is our pre-hospital medical information system. And this is essentially the pre-hospital patient care report. So everything that is contained, everything that happens to the patient from the time that EMS is dispatched to the call, to the time they arrive from the call and take care of the patient and transport them to the emergency department, that'll all be contained within PREMIS. So a little bit about PREMIS. There's two ways that you can submit data to the state through PREMIS. There's the vendor PCR import system. Essentially what that means is there are a host of third-party software vendors that EMS agencies will work with locally to collect their data. Those data then get transferred over to the state data system and mapped into the state standard, and we'll talk about that in a second. There's also the ability to enter data directly into the state data system as a web-based entry. The large majority of our calls come in through the web-based, through the import process. The web-based process in North Carolina the past couple of years accounted for about 4 to 6% of the total PCRs we get. And we'll get, in North Carolina, there are about 2 million EMS events a year, and about 75% of those are 911 calls. And here's how this is the user interface if folks wanted to enter directly into the state data system. So in North Carolina, it's required within 24 hours of the EMS event that the patient care report is submitted to the state data system and entered into PREMIS. We do things like to assess data quality and data completeness once it is in the state data system. But it is a requirement. The 24-hour requirement is that's been in effect for quite some time. So, and this is any time a patient is in an ambulance. So not just 911 calls, but medical transports, inter-facility transports. Anytime a patient's in an ambulance, that record should come to us within 24 hours per rule. These data are collected on what is called the NEMSIS standard. That's the National Emergency Medical Services Information System standard. Right now, we're on version 2 of that standard. Now, the NEMSIS, this is a national standard, so EMS is one of the few fields where data are collected in a standardized fashion nationally. And there's a version 2 standard. You can get this data dictionary from NEMSIS.org, but there are a whole host of NEMS national elements that North Carolina does not require that are submitted. Here you'll find a list of the elements, the data elements that North Carolina does require. And you'll see on the far right, that column will tell you what elements are required in North Carolina. The one closest to that, that's labeled NEMSIS, that tells you what's required for the national data set. And as you can see, there's a whole host of elements that you can pick through. Most notably, you'll see we have one of the most important things in utilizing EMS data are that we have location information. So you can kind of identify if there is a increase in overdoses in a certain area within the state. You'll be able to identify those relatively quickly at the incident address things here. Here's where you'd identify some medications, what medications were given. And that leads me to this point, which is really important to understand that EMS providers treat based on the patient's signs and symptoms. Pre-hospital, we don't have diagnostic equipment, so we can't identify specifically which opioid was used by the patient. However, based on their signs and symptoms, the overdose patient will be administered pre-hospital naloxone, and that is how we can track opioid overdoses pre-hospitally. In the EMS. So in order to do that, you're going to track Narcan administration. There are a couple of data elements that you're going to want to look at, and here are some of them. Obviously, you're going to want medications given. Date time administered will let you know if there was multiple administrations during that event, and you can find the dosage information with these 3 elements. And then with the other elements, you can slice and dice them by demographics and so on. If you look there, North Carolina is one of the few states that have state-level EMS protocols. So it's not just standardized on a regional level or a local level, as most states. These are statewide protocols. And you'll see here, this is the recommended Narcan dose from the state. There's a peds dose, and there is a adult dose. Now, and you'll see these colors here and here tell you what level of provider can administer the Narcan. So in essence, you have to be at least an EMT basic. So here's a B, if you want to give IV or IO, you have to be an advanced EMT, and paramedics can give any level. So here's the first page, and you can see that all the EMS protocols are available on this website here. This is the overdose protocol. Here's the second page of this protocol. I put this up because there are some interesting additions that folks may want to be aware of. This first one that indicates that there are circumstances where up to 10 milligrams of Narcan will be administered. That is new, and that is in correspondence to the need, basically, because of because of heroin being mixed with fentanyl and carfentanil and other drugs that are just not as responsive to Narcan. And then down here, that's highlighted here, it tells you who can administer Narcan and by what route. So the EMS data gives us an opportunity to do some interesting things. Here you can see we broke down Narcan administration from 2016 for overdoses by county. So you can see where the most Narcan is administered, and if those follow some interstate and highways and so on. And we can even break it down further to look at the zip code level. And then if you so choose, we can cut this by male, female, who's administering the Narcan, and so on, other types of important demographics. So now that I've given you all this information about Narcan and what you can do with EMS data, let's talk about how you might obtain these data. So these data belong to the North Carolina Office of EMS, and if you want to obtain some of these data, the first thing you might want to think about is this data request form. This is available on the North Carolina Office of EMS website, or you can contact me and I'm happy to forward it to you. This has to be approved by the North Carolina Office of EMS, but you would fill this form out if you're looking for simple counts, percentages, anything other than a formal kind of research data set. You'd want to go with this data request form. If you're looking for a research data set and you want to do your own analysis, then there's a little more paperwork that's required. This is the North Carolina Data Use Agreement, and I just took a couple pages out of it. It's 7 pages when you haven't filled anything out, but you'll have to know where you have to fill out who the data are going to, the purpose of the request, what you'll do with these data, and when you're expecting them by. As you can see, there's a lot of signatures that are required from the Office of EMS to obtain these data. Now, the Office of EMS is very supportive historically of research. So if you have a good question and you're not asking for too many patient identifiers, in my experience, they've been very open to sharing this information. And I can work with anyone on the call to help streamline your data use agreement to make sure that you can use these data in a timely fashion. So when you're requesting data, it's always a good idea to look at what elements are required in the state and look at the data dictionary to make sure that you know what you're requesting. And you're going to want to put in an appendix something that looks like this, just with the element number and the element name. You can find the element number here. Element name is here. And you go ahead and include that as an appendix to your data use agreement, and that'll help streamline your request. So right now, we're currently on the NEMSIS version 2 standard. In the very near future, in November, we'll be moving to the NEMSIS version 3 standard. It'll be a good move. The data set is a little more robust, so it'll help discriminate a little bit more and get a lot more information in the calls on each call. They're also implemented a lot more standardization, so they'll be using ICD-10 codes, SNOMED codes, and RX norm codes. RX norm codes are going to be important for any Narcan data request after November, because in version 2, as you can see here, the SSD data type up in the top left corner, these are string variables, so we relied on the correct spelling. And of course, we've done some normalization for spelling errors for when you are doing any type of Narcan request. But that goes away in version 3 because we'll use an RX normal code. And that code will facilitate or alleviate the need to normalize for spelling errors and so on. So I want to thank you for giving me some of your time today. And I'm available. Please let me know if you have any questions. Put my contact info up for anyone who's interested in obtaining these data or just has a question about how you may use EMS data in the future. I think I stopped sharing my screen prematurely. It looks like there is a question about the data request form. You can get the request form on the North Carolina Office of EMS website. You can also contact me, and I'm happy to forward that to you. The most current date of data, looks like we've got another question from Julie. The most current date of data is yesterday, so data required to 20 hours after the EMS event, and the large majority of data do meet that standard. So you can get data all the way up as current as yesterday. For research purposes, you probably want to go, you probably don't, we've been collecting data in North Carolina since about 2004, but you probably, for research purposes, you probably want to use data for about 2010 and on, just because of improvements in data quality and completion. And just for a point of clarification, PREMIS is not the national database. PREMIS is the North Carolina database for pre-hospital emergency care reports, but they are collected on the national standard. And I think that's it. And I will stop all the time now and pass it over to Amy.
All right, thanks, Tony. Can you hear me, Tony? I know not everybody can respond.
Yes, I can hear you.
Okay, great. So thanks everybody for logging in this afternoon. I'm going to go very briefly over NC DETECT, what it is, how you can access the data if you're affiliated with a health department or a data provider, and some other ways to access the data if you're not. So NC DETECT is a data system with a secure role-based web application, and it was built for health departments, hospitals, and other data providers to view near real-time information on emergency department data, EMS encounters from PREMIS, from the system that Tony just described, and calls to the poison center. We've been collecting data similarly to PREMIS since around 2004, but really was statewide starting in 2008. And NC DETECT is funded primarily through the Division of Public Health Communicable Disease Branch using CDC funds. So just a little bit more detail on the data that flows into NC DETECT. So these different systems are collecting data for their normal operations. They're not doing any data entry specifically for NC DETECT. We're just extracting a subset of that data for use for public health surveillance. So the emergency department data come in twice a day. The EMS data from PREMIS come in once a day, and the poison center data from the Carolinas Poison Center come in hourly. We also share our emergency department data with the CDC through the National Syndromic Surveillance Program. To give you an idea of the, I don't have a data element list for all three of those data sources, but it's a subset of data, it's de-identified, but we get enough information to have a little bit of clinical information as well as administrative information. And the other key point is that we are receiving both free text data and diagnostic data. So we try to use both in many of our case definitions or reports so that users can see the benefits of using both of those types of data. Sometimes it makes sense to use the codes, and sometimes it makes sense to use the free text. And sometimes we use a combination of both, and I'll show you examples of those in a little while. We started receiving race and ethnicity back around, started getting complete back around 2016. So that does not go all the way back to 2008. The demographic information we get, so the city, county, state, unlike the premise data that Tony described that has an incident location, all of our location information is tied to the patient's county of residence. So within NC DETECT, although it was funded primarily and continues to be funded primarily through communicable disease, we offer over 100 different indicators on different issues of interest to public health. So injuries, anything from heat-related illness to opioid overdoses, which we'll be focusing on today, infectious diseases such as tracking the influenza season. We have a variety of indicators that are useful for monitoring pre and post disaster. We'll set up special monitoring for mass gatherings, such as the Democratic National Convention that happened a few years ago. And we also have a few indicators for chronic diseases and occupational health. And you can see all the different things that we track on our website. If you go to ncdetect.org, under Data and Reports, there's a link to our emergency department case definitions. The EMS and Poison Center definitions are available on NC DETECT after you log into the system. But if you have an interest in seeing what those are, you can contact me and I can send those to you. So specifically regarding overdose and substance abuse, we have probably, I guess, over 15 different indicators now. This is just a aggregate view of what we have. We have some overarching medication and drug overdose categories that look at any medication or drug. And then we have subsets that go into more specific categories for things like heroin, other synthetic narcotics. We also have some substance abuse categories looking at alcohol and drug abuse. We use our keywords to try to track emerging drug threats, so for synthetic cannabinoids, bath salts, things like that. We'll set up a keyword report looking for mentions of those from people coming into the emergency department. We also have some reports that track the naloxone administrations that Tony described earlier, that you can see we don't get the full premise data, we get a small subset, but you can see some basic demographic information as well as the medications given. We don't receive the dosage or the times for that, but we do get the medications administered. And again, you can look at our case definitions to get more detail on how we're querying the data we receive to build these reports. For those of you who are affiliated with a hospital or health department who don't already have an NC DETECT account and are interested in getting one, if you go to our homepage, ncdetect.org, you'll see an account request link. You can complete that form, and that will go to Division of Public Health for review and approval. And then once you have an account, you just go and you click on the login button to log into the system. It's available 24/7. This is an example, a screenshot of one of the reports available to our users. This is a dashboard that shows several of our different indicators all on one screen. If you scroll down, there's a few additional graphs. This one is a rolling 30-day view of ED visit count. So this is emergency department data. You can see there's two lines. The blue line is the current year, and the gray line is the previous year. And one of the things you'll notice is a similar trend across the different indicators. So if you'll remember, the medication or drug overdose is kind of our overarching category, and then opioid overdoses would be a subset of that. And then the heroin overdose would be a further subset of the opioid overdoses. So any one ED visit, so if you have an emergency department visit that has a code for a heroin overdose, it will be counted in all three of these indicators: the heroin overdose, the opioid overdose, and the medication or drug overdose. On these dashboards, you can do a county comparison to a statewide comparison, as you'll see on this example below. And users who are authorized to view line level data can click on the county level graphs to review the de-identified line level data that we have. You'll notice these, these red stars that we have on the dashboard. That's a simple algorithm that looks for counts that are higher than expected compared to a moving average from the recent past. And it will flag those counts that, that appear to be high. This is one graph from that dashboard I pulled out and made a little bigger so it's easier to see, just to illustrate some of the data that Tony was talking about earlier. This is, we look for medications administered in that free text data. So we look for mentions of naloxone or Narcan, and then just count them by agency, county, and this is a statewide view, and you can see the current year compared to the previous year. And just a reminder that naloxone is used for things other than overdose. So this is a really helpful indicator, but not all of these are necessarily opioid overdoses. When you're in NC DETECT, you can see in this one custom event line listing report, we have a variety of overdose and substance abuse indicators, and there's a prefix that organizes them alphabetically. As a user, you can log into the system and look at data going back to 2009 for most of our indicators. If there is one that has ICD-10 CM in parentheses, that can only be used when ICD-10 CM became effective, which was October 1st of 2015. So you can't get data for that report prior to October 1st of 2015. When you're reviewing the line listing data, this is not all of the data you have access to, but these are some of the more important data elements I wanted to highlight. You can see here the chief complaint is pretty brief, and the excuse me, the triage note provides a little bit more detail. The triage note is not a required element, so not all hospitals send it, but for those that do, it can provide additional contextual information. And then you see the ICD-10 CM code listed below. This is kind of the data we like to see, a chief complaint, a triage note, and a diagnosis code. That's not always how it happens in reality. This is another example of some complete data, but expresses some of the challenges we're facing when trying to do surveillance for fentanyl. The first column we assume is regarding an overdose, an unintentional overdose for prescribed fentanyl, whereas the second column looks like it was fentanyl that was used that was not prescribed. You'll notice that they both get the same base poisoning by other synthetic narcotic diagnosis code, which makes it hard to track opioid overdoses, prescription opioid overdoses. We used to have a report called prescription opioid overdoses, but we have removed that because we don't feel comfortable saying that every single ED visit in that report was for a prescribed opioid. One of the other challenges we see is diagnosis codes that are non-specific being assigned to what appear to be overdose visits. We don't get all of the information that a coder uses to assign a diagnosis code, so there might be information that indicates alternative information, but when we are looking for specific poisoning codes and they are not used, they won't be binned into our visits, which is why we have a few case definitions that look specifically for the keyword. So we have one report, medication or drug overdose keyword, that will pull the visit if it mentions overdose in the chief complaint or triage note. So you would be able to see this visit in that report but you would not see it in a report that looked at diagnosis codes only because of the non-specific code used here. Similarly, we also get visits that don't get a diagnosis code. Either they're coming later, several weeks later, or they don't get assigned at all, either because of a data quality issue or because the patient left before a diagnosis code would be assigned. For people who leave against medical advice or leave without being seen, we might not get a diagnosis code. But this particular visit would be binned into several of our reports. Again, the medication or drug overdose keyword report. We also have keyword reports for heroin, cocaine, and other synthetic narcotics where the fentanyl would be included. I just encourage you to get familiar with the data that we get for your jurisdiction if you are interested in drilling down and kind of knowing how strong your data quality is in terms of diagnosis code, so that you know the best reports to use for your jurisdiction. So just to summarize, we get the data very quickly, twice a day. It's very flexible. We can build new case definitions to track emerging threats very easily, and it's statewide. But we have no control over how these data are entered. We're using it for public health surveillance, even though the data was generated for other purposes. And there are some challenges with using the ICD-10 diagnosis codes that we're continuing to monitor and evaluate to make sure that we're providing you with the most appropriate case definitions we can. For those of you who are not affiliated with a health department or a data provider, you can view NC DETECT data in some static reports that we're working on. And we also have, I don't have any slides for it, but we also have a data request process for research data requests. If you go to our website, ncdetect.org, under data and reports, there is a link to data requests for research, and you can get more information there. The Division of Public Health has been disseminating some static reports, and we've also been working on some. This is one example, and I know the font is really small on your screen, but this is a breakdown of 4 different indicators by sex and race and age group. And then on the second page, you can get a breakdown by insurance coverage and by disposition. So insurance coverage is high-level groupings: insurance company, Medicaid, Medicare, other government payments, workers' compensation, self-pay, other, and unknown. What we see in the in the opioid overdose data is a fair amount of self-pay, especially if you look at heroin, which is that third row on the top. About 53% of heroin overdose ED visits are self-pay or uninsured. The next category, disposition, tells you what happens to the patient after they leave the emergency department. Were they transferred, discharged, admitted, or died, or other categories. Most of the best place to track mortality data is the data from, not in NC DETECT. We do not have mortality data in NC DETECT, and most people, there are ways to track people who die in the emergency department, but that's not going to be reflective of true mortality statistics. So we encourage you to work with Scott Preshabell to get the mortality data you need for your jurisdiction, and he can point you in the right direction for that. So that's it. Here to take questions. Again, encourage you to go to our website to get more information. So thank you very much for your time.
Hey, Amy, it looks like you've got one question right now from Roxana. I love this new report. However, it does not print out so well, so all the weeks are seen. Can a print feature be added?
Oh, to this static report? Sure, that's great feedback. Thank you.
Yeah, and just to go along those lines, I mean, some of these reports have just essentially been developed, and we are, asking people who are out there using them to provide us feedback. So if you're not seeing what you want to see, or want to see it in another way, or think of a different report entirely, contact Amy or myself, and we'd be happy to try to, we're not it might not be possible, but we certainly would take all kind of feedback and input. Looks like a couple of other questions have popped up. Amy, I'm not sure if you're seeing them or if you want me to read them to you. I can do either thing.
I think if I stop sharing, maybe be easier. Okay, so if you're interested in the static report, they were disseminated via email. So if you did not get a copy of it, just be sure to contact me, and I'll make sure you get the copy for your county. And we are working on a way to those static reports to make them available through NC DETECT, so you could log in and just download the PDF. That's something we're going to be working on this summer, so hopefully that will be available come this fall.
And again, this is Scott. Tony, I'm going to ask you a couple questions too. I think while people are putting their questions in, I just wanted you to just give like a 2-minute update on what South Carolina is doing in terms of their naloxone administration by law enforcement, because North Carolina is considering something similar, and I know some groups know and some don't. Do you want to provide just like a quick snapshot of how South Carolina is doing that?
Sure. So we have we worked with South Carolina. It started with just the sheriff's department, and it's expanded since then. But for law enforcement officers to be able to report their Narcan administration, it is essentially a very short form that's similar to a PCR, where they can report what they gave, how many administrations they gave, if the patient improved or not, and then what EMS unit arrived on scene. The biggest utility of this is not just tracking law enforcement administration of Narcan, but we also have linked up in South Carolina with their pharmacies statewide. So after an officer delivers or administers Narcan, the pharmacy automatically gets notification that that dose was delivered, and the officer can go to a local pharmacy and pick up another dose. We're working on implementing some information about expirations of the doses that they're carrying, giving some notifications for that. And all that is fed to the South Carolina State Office of EMS. For reporting, we provide reports, and they use it for training purposes and logistics and so on.
Thanks, Tony. So again, that's something that North Carolina is kind of exploring at the moment. Right now, what happens is the North Carolina Harm Reduction Coalition, which is a private nonprofit in the state doing a lot of work around overdose, has been reporting the community administration of naloxone and law enforcement, and they will probably continue to report the community administered naloxone. But I think that there's ways to potentially integrate to create a state system that will help us do that for the state. So again, that's something that the state of North Carolina is looking into. Will help them with supply management as well as some of the reporting purposes. Tony, another quick question for you. The NEMSIS 3.0 is coming to North Carolina. It sounds like in November will be rolled out. What does this mean? I mean, how will it impact the data, and then more specifically, how will it impact the overdose data, or will it be seamless from the user end?
Just one more point on I failed to mention that the law enforcement tracking of Narcan administration, that is subsequently linked up with the pre-hospital care report, so we can track that throughout the event. But in terms of NEMSIS and the change in the NEMSIS standard, so NEMSIS version 2 it's a pretty old standard. It wasn't linked up to today's standard of care. NEMSIS version 2 came out in the mid-2000s. So they're moving to version 3, and it really does provide a lot more robust data set where you can get a lot more information that's relevant for today. So something that's stated earlier is that instead of having to look for spellings of Narcan and having folks spell it the wrong way or acronyms or so on, We're using RX norm codes in the NEMSIS version 3 standard now, so that'll make it a little bit easier to get accurate numbers for Narcan administration statewide. We also, the NEMSIS version 3 standard has some information on different information on providers and what all the providers can do. There's been some changes in certification levels over the years, and the NEMSIS version 3 standard can adapt to that. And it's more customizable. So I showed you the list of version 2 elements that North Carolina requires. In version 3, they have the ability, North Carolina has the ability to add their own custom elements as long as they meet the schematron standard. And North Carolina has a few of those to make sure that we understand exactly what's going on the call. So for instance, for Narcan, if folks were dispatched to an overdose call and we don't have a record of any medications being given, with the version 2 standard, it's pretty difficult to tell if that's an issue because of missing data, or if it's an issue, or if no medications were administered, or why that field isn't there. And we've added some custom elements in North Carolina to make that abundantly clear if a medication was not administered, or to identify if it is missing data, and then we can follow up with them to try to get that filled in a little better.
Great, thanks for answering those questions. Amy, I know you answered a question offline, but I want to just put it out to the group as well. So for NC DETECT, the official authorized users are either local health department, state health department, or healthcare facilities. And so if you're not part of those groups at the moment, that's the only way you would be able to access that data at the line level. And so if you find yourself in that situation, you need to reach out and partner with some of those groups. We are working to try to widen part of that definition and to allow some access, particularly to some of these static reports that Amy kind of displayed. But Amy, I have another quick question for you. And again, encourage folks to ask questions. Looks like we might have a couple out there already, but what are the advantages and disadvantages of using keywords versus the ICD coded data, and for some of those definitions?
Sorry, can you repeat that?
Sure. What are some of the advantages and disadvantages of using keywords versus using the coded
right.
ICD coded data?
So I talked a little bit about that. So the keywords can be really helpful when a hospital either sends their codes late or doesn't send them at all, or uses non-specific codes like the other poisoning or other substance abuse types of codes. And there are hospitals who do that. The challenge with the keywords is, as Tony mentioned, I mean, people are busy working in the healthcare setting. They use abbreviations and things are misspelled, and so we have to do our best to capture all the different permutations of how somebody would spell heroin or how they would record overdose. And so, you can miss visits if you're looking at the keywords only, and you can also potentially introduce false positives. So, for example, OD. Big O, big D is a common clinical way to write right eye. So if you're ever looking at the medication or drug overdose keyword report and you see an eye-related visit, it's because we didn't exclude that one as well as we should have. So there are some challenges with the free text data, but they can be really valuable if there are some other data quality limitations.
And Amy, it looks like you've got a question from Norma. I'm not sure if you've had a chance to read it, but
yes, so let me explain a little bit more about how you can view the data in NC DETECT. If you're looking at a graph, say on our dashboards where it says county, that is based strictly on patient county of residence. So any residents of that county, regardless of which hospital they visited, would be included in that graph. So for example, if you have a patient from Cumberland County but they go to Duke Hospital, they would show up in a report that is based on County of Cumberland, because that's based on their county of residence. You can also look at data by hospital in NC DETECT. So for example, if you are a Wake County epidemiologist, you can see data for the Wake Meds and Rex Hospital and Duke Raleigh. You can look at data by those specific hospitals, and they will show you everyone who went to that hospital regardless of their residence status. So sometimes it's helpful to look at the data by hospital, especially if you live in a part of the state where you have people from out of county using your facilities and you still want to see what's going on. But looking at data by county is specifically patient county of residence.
Great, thank you. I just want to follow up too for Amy and maybe Tony to a certain extent. This, I think, was mentioned by you, Amy, about naloxone. Sometimes naloxone isn't used for overdose. I think what happens is sometimes EMS arrives and it's a suspected overdose, so they use naloxone. I'm not sure if there's a lot of alternative uses for it. I think it's pretty specific. But, you know, when EMS is there and there's a body on the ground, essentially they think it's a suspected overdose, they might use naloxone. Now, eventually there might be some diagnosis that doesn't align it back with an actual opioid overdose. Of course, in many cases it does as well. So that's why a lot of times you'll see EMS reporting, I think they're using up to 40 naloxone a day or something like that in our state, or averaging 40 naloxone administrations. And so you can't say, well, they've administered 40 naloxone, so therefore we've had 40 overdoses a day. We wouldn't know that definitively until those patients and others are seen by medical healthcare professionals and diagnosed kind of on that side. And we're trying to link some of those things up, and I know Tony mentioned it a little bit earlier in that. But Tony, you want to clarify that a little bit more?
So again, it's signs and symptom based, so they'll look for things like pinpoint pupils and decreased respirations and so on before they administer Narcan. However, the new protocols, statewide protocols, have just been released, and Narcan has pretty much been taken out of every other protocol except for overdose. There used to be a time when Narcan was administered kind of as a last-ditch effort for cardiac arrest if you didn't know what was going on, and it was in a couple of other protocols. But the newest protocols have pretty much limited Narcan use to specifically for overdoses. So that shouldn't be too much of an issue going forward. However, to your point, we don't pre-hospitally we don't diagnose, so we can't know for sure that it was an opioid overdose until we get those data linked and do some kind of longitudinal analysis on that.
Great, thanks. So again, it looks like there's a quick one that's popped up for Amy. Currently, is urgent care substance use related date included in county data? We understand that using urgent care data is in a pilot status right now. Can you talk more about the urgent care data?
So you can look at substance abuse ED visits right now in NC DETECT. The urgent care data is only in the Charlotte-Mecklenburg area, so it's not statewide. We have just a few case definitions running for that urgent care data. I'm not sure where you're located, Norma, to know if that's helpful to you. And there are no plans to expand the urgent care data to become statewide. There's not enough resources for that. But if you are in the Mecklenburg area, you can use that data.
Great. So we've just put a last call out for questions. But just before we do that, if Amy and Tony, do you have any last thoughts about your data system and how you want people to use it around overdose? And then I'll follow up. I'll wrap up things here in a minute or two.
I'll go first. I think that EMS data is certainly underutilized. we get some data requests. We've been getting more and more as it relates to overdoses from some federal agencies and state level agencies and so on. But the Office of EMS is very supportive of other analyses, and they collect these data. One of the specific reasons they collect it, other than improving performance and care in the field, is they support research. So the data are available, and if you have a concise question, usually the data use agreement gets approved relatively quickly. And I'm happy to work with anyone on their DUAs or data request forms if you choose to fill one out. And I hope we can get some good work done.
Yeah, I'll just echo what Tony said. We have a lot of interest in using the emergency department data, specifically for overdose. We're still learning, especially with the transition to ICD-10-CM, how to make those reports as useful as possible. So I would just encourage you to don't be shy. Please reach out to us if you have any questions or concerns or suggestions for how to get the data you need for your work. We are here and ready to work with you, and please contact us.
Great. Again, thank you both for presenting today. I really appreciate it, and I know the group does as well. And now I want to thank everyone who attended the first webinar on the series around tracking and measuring the opioid epidemic as a prevention tool. Also want to remind you that this webinar has been recorded, and it will be sent out later today in an email. I hope you'll be able to join us next month, where we'll look at data from North Carolina's Controlled Substance Reporting System and hear a little bit about some of the studies that the UNC Injury Prevention Research Center have been working on. Again, if you want to find out more information on these presentation or future webinar topics, please visit the website that we've posted in the chat box. We're really close to the hour. Thank you all again for being here today and for all the great work you do. And if there's anything else we can do to help support some of your efforts, please let any of us know. Otherwise, thanks again for joining, and we'll sign off now. Thank you.